So, good afternoon, everyone. Welcome to our first T-CAIREM trainee rounds of the summer. We're really excited to kick off this series, which brings together some of our summer students, our members of the broader T-CAIREM community, and our peers to showcase the innovative work of our trainees. So today we'll be hearing from two presenters. Each will have 20 minutes to present, followed by 10 minutes of Q&A. And we will first invite questions from our adjudicators, and then if time permits, we will also open up the floor to any questions from the audience. So if you do have any questions, feel free to type them in the chat from the audience. And I just wanted to remind everyone that this presentation will be recorded. So first up, our first presenter is Ghadir Ali, a PhD student from the Department of Electrical and Computer Engineering at the University of Toronto. Ghadir specializes in natural language processing for healthcare applications, focusing on AI-assisted clinical documentation to improve efficiency, accuracy, and usability in clinical settings. And now I'll hand things over to Ghadir to start her presentation.
Okay, thank you so much, Julia. I'll start sharing my screen now. Is the screen visible?
Yep.
Okay, great. Thank you. Let's get started. So, my name is Ghadir Ali, and the project I am presenting is regarding balancing automation and expert oversight, specifically evaluating LLM-assisted clinical documentations, but through a clinician-centered lens. Our research team is me, a PhD student at ECE at University of Toronto, and I'm working with my two amazing supervisors, Professor Irvin Sejdik, who is a professor at U of T and also the research chair at North York General Hospital, and Dr. Nihal Haq, who is a geriatric and hospitals at NYGH, and also an adjunct professor at U of T. I just wanted to acknowledge our clinical partner for this project, which is North York General Hospital. North York General Hospital is a leading community and academic hospital based in Toronto, Ontario, affiliated with the University of Toronto. And it serves a diverse population of approximately 500,000 residents across North York and Central Toronto and Southern York regions. NYGH is acknowledged as a leading in deploying technology for healthcare, and it's also recognized as one of the top community hospitals in Canada and globally. So it's an honor to be working with them on this project. So we will start this presentation by a background and research gap, just identifying what has been done, where we stand, and then our proposed solution, and then finally some preliminary results and acknowledge the limitations of the study because this is a very realistic project. So there are a lot of points to just keep in mind when we are trying to approach a topic like this. Okay, so let's start with a little bit of a background. The modern healthcare system has a lot of documentation and a lot of healthcare records that are being kept for a variety of reasons. While a physician's main goal is to care for the patients, it's noted in the research that approximately 50% of their time and effort is spent on documentation-related tasks, whether they are generating documentation, summarizing documentation, extracting information from documentation. This does not just take away from their time to directly care for their patients, but it's also contributing to burnout, the high turnover rate for the medical profession, all in all contributing to lower efficiency in our healthcare systems. So we need to find a way to facilitate or automate this aspect of healthcare. But the issue is that we have a lot of text. And when we talk about trying to summarize or process text intelligently, obviously the first solution that comes to mind would be large language models or LLMs, given the huge success they've had in other areas, well, basically everywhere. So could we actually take that success and make use of it in healthcare? Well, the answer in research is that we have a lot of studies actually working already on that, and they can show that LLMs can achieve comparable performance to human physicians, which is a huge milestone to be achieved, showing that there is great potential there. And that's so great, but what's the problem? Well, we have identified several research gaps. The first one is the data. So, medical data is highly sensitive, and there are a lot of privacy regulations around it, as of course should be. So, most of the research we've seen uses synthetic data or retrospective data, which doesn't really reflect how it goes in clinical day-to-day practice. The other issue is that proprietary models are mostly used due to their high performance compared to other open source models. But the issue with proprietary models is that we don't really have control over the data flow, where it goes, how it's processed, which is a huge concern and a big ethical dilemma when it comes to sensitive medical data and protecting the privacy of patients. We also don't have full flexibility to tune or adjust the model the way we actually want it to tailor it to the best results that we want. And the final and most important point is the setup of these experiments are usually trying to benchmark LLMs against human physicians, which is a great first step. But realistically speaking, this will never really be what happens in day-to-day clinical practice. LLMs or AI in general cannot actually be a fully autonomous solution. So in reality, the more likely scenario is that they will function supervised by a human physician. However, this has yet to be explored. So it's not enough to actually say that, okay, they work great and we can compare them to human physicians. We need to know how they work with physicians in a collaborative setting. Because when we ask physicians to review and make any necessary adjustments, this adds another burden that wasn't calculated, which is the burden of review. So they need to be aware of everything the LLM is generated so that they can approve or make any necessary corrections. So would this overall be a good solution, or would it not really enhance the process overall? And that leads us to our research questions, which is the first one, the usefulness of this solution. Would this actually decrease the time and effort in terms of cognitive burden for physicians, or would it add more cognitive burden, or would it not make an effect? This is what we aim to address. And with LLMs, since they are never 100% accurate, there's always a risk of hallucinations, fabricated informations, a lot of issues that can arise. So we have to ask the question, since patient safety is the number one priority, would integrating this solution cause some sort of risk to patient care? And of course, since LLMs are general purpose, we want to ask, how can we make it better for our specific use case for healthcare and in that collaborative settings? So we want to explore all of these three aspects. And we also introduced this new concept of context-aware experts. So our hypothesis is that the performance of a collaborative LLM or AI model in general doesn't just depend on the performance of the LLM, but it also depends on the human user that utilizes the system. So if the user is an expert in their field, they are more likely to make better use of the system. And if they are context aware, meaning they are familiar with the case at hand, for a physician, for example, they would be familiar with the patient history. So they are much more likely to make better use of the system than a user who may not be an expert or may not be familiar with the context of this specific case. So we are trying to test the system end to end with the human in the loop, or in this case, the context aware expert or CADEX in the loop, which is built on top of the framework of a human in the loop. Our proposed system works overnight. So we have inpatients with generated progress notes every day that hospitalists write. So these progress notes are collected and bar chart nightly and then processed using the LLM. And then the summaries are generated automatically and stored in SharePoint, which then hospitalists can access in the morning so that they can review them, make any adjustments, or approve them how they see fit. So this doesn't interfere with their day-to-day operations since the processing is done overnight. And our system is we are using Azure AI, using a serverless deployment with private endpoints that is only accessible from on-premise network to make sure that the data, the model, all of that is protected and the privacy of the patients is preserved. We are also using Meta Llama 3.3 model, which is an open source model, because we want to see if we can actually get open source models to achieve acceptable performance in this scenario where they are actually supervised by humans and we're not pushing for a fully autonomous solution. So we can get the best of both worlds. We can get the performance and also make sure that the privacy of the patients is respected. Our methodology is we start with a pilot study to deploy the system to a limited number of physicians who are participating with us. We collect open-ended feedback and just iteratively improve the solution through prompt engineering, through just the system design, any way we see fit based on the feedback that we get from them. Once we get to a point where the system is performing to a satisfactory level, we can introduce the system to the full of group of participants and collect pre-study qualitative feedback while introducing the system to them, how to use it, what to expect, and so on. Finally, we'll go to the live testing. Participants will use the system for approximately 2 months or more, depending on how the time permits. And then we will collect information of the usage, how much they access the data, ask participants to fill out surveys, and so on. So this is our quantitative data collection phase. And then, of course, we will analyze the data to reach the final results. Currently, we are at the pilot study phase, so we are doing iterative refinements of the system, mostly through prompt engineering from the feedback that we get from a limited number of participants. So when we say that we are collecting qualitative feedback before we introduce the system to our participants, we are doing a semi-structured group interview where we are working with them to understand 4 key points, but also leaving the floor open for any perspective that they may have. So we are asking them what they know about LLMs. Do they know what type of errors are to be expected? What are their expectations from this experiment? Their openness to participation, because all of that might affect how they see and evaluate the overall system. And then after the live testing, when they have used the system for 2 months, we collect the results via a survey. We mainly try to measure the accuracy of the generated discharge summary, the usability of the overall solution, and the risk, of course, is a major factor that we always have to consider. The efficiency of the overall process, like if we actually integrate all of that, did it eventually make things easier or harder or no difference for the physicians? And then we leave the room for open feedback because this is a clinician-centered study. So we want to hear from clinicians how they see things and not just ask questions from our point of view. So we have some preliminary results from our pilot study. When we measure the accuracy in our survey, we ask them to rate the correctness on a Likert scale from 0 to 10. So the average was 7.5 out of 10, which is a great result. We asked them to evaluate the completeness, meaning that the discharge summary did not neglect any relevant information. This one scored a bit low, so it was 5.5 over 10, which is an issue we're currently addressing, trying to make sure that all the relevant information is contained. We also asked them to evaluate the clinical sense. They have rated that 8.5 out of 10. Then we evaluate the usability through clarity and conscientious, making sure that the generated summary is as clear and as concise as it can be, both rated well. We asked for the risk, and they evaluated the probability of risk and the severity of risk, both rated very low, which is good. And then we asked them to evaluate the efficiency. They have reported that their time to review the generated discharge summary as opposed to manually generating it from scratch, the time required was reduced by 40 to 59%, and that the cognitive burden was moderately better. We also asked them for any open feedback, and the general key points that we got was formatting and the way that the summary was worded. They said it's a little bit ambiguous sometimes and not really similar to how a human would write it. So we are currently working on addressing that. So some key limitations to point out for our study, which is the first one is that we are relying solely on self-reporting, which can be subjective. And there might be some bias because the physicians
你手还挺稳的。
are aware that this is generated by an
然后
LLM.
能在直接拍照呢？
And there are some threats to external validity because we are using a same participant of a group. They all have the same background. They all work in the same department, so we're not really getting a lot of different points of view. And we are only using one model, which is Llama 3.3 with fixed configurations. So this leads us to our future work, which is we want to include more objective metrics, such as actually measuring time instead of just relying on self-reporting time. And we want to make it a blind study. So there will be some discharge summaries that are generated by human physicians versus others that are generated by LLM. So the human evaluators wouldn't know which is which. This mitigates the bias. And we want to expand to multi-center study for better generalizability. And finally, we want to experiment and benchmark different models with different configurations to see what works best and to test the idea of, can we actually get open source models to perform satisfactory? So for the current study, our main goal is to test the feasibility, applicability, and potential of this solution. And if we receive favorable results, which we are currently on track to get, we want to actually involve more quantitative metrics that involve automated metrics such as measuring time and also a human in the loop. And we want to focus on bias mitigation and generalizability through multi-center study. The final note or key takeaway from this is that while research has established a solid background, we have yet to see this value realized in clinical day-to-day practice. This is because the scenario that is being built is around the LLM, kind of mostly just performing autonomously, which is not really likely to happen. But we want to start testing and developing LLMs with the key idea in mind that they will always be supervised by a human expert. And we want to test the solution end to end if we want to actually see any realizable gain or any value added to our healthcare system. So that's it for the presentation. Thank you. If you have any questions.
Awesome. Thank you so much, Ghadir. That was a really lovely presentation. So now
Thank
we'll
you.
move on to the 10 minutes of Q&A. I'll first invite the questions from our adjudicators. Is it okay if we start with Anne? Yeah.
Okay, so that's a really nice talk and a very clear summary. So on your kind of results so far, the only thing that seemed to be underperforming was the completeness. So I was wondering what kinds of things is it that the model is failing to pick up? Where is it kind of losing information? Do you know?
Yeah, I can recall a few specific cases. So, for example, first, when we were doing prompt engineering, we wanted to focus on different issues that the patient was facing, and we realized that it was dropping some. It was mostly focusing on maybe the most recent ones. So we told it to summarize each one with like the key investigations that have been done and all of that. But we noticed it was still dropping some details. Like one case, a patient was not admitted with a fever. They developed a fever while in hospital, but then it was resolved, and the test showed that it was not actually significant. So when they were charged, the fever was not present. However, the model failed to actually mention that. Maybe it thought it wasn't relevant since it wasn't something they were admitted with and it was resolved, and there was nothing like there were no consequences or anything like that. But when we asked our physicians, they said that this is a key important information that should have been involved. So the issue is, I think, is that the LLM looks at the patient notes the way a human would look at them, not as a physician. Like for me, for example, when I was reviewing them, I thought that was fine because it's like if it was resolved, then do we really need to mention it? But this was important medically, and this is why we need the clinician-centered lens. We need the feedback that can tell us what are important information, because LLMs are general purpose and they are not really picking up on these details yet.
Awesome. And now we can move on to another question from a different adjudicator. Deepang, is it okay if you ask your question?
Yeah, thank you for a nice presentation. So I want you do the survey. So I think the survey you conducted, you kind of ask a survey to the physicians, right?
Yes.
So I'm not sure how kind of a patient's perspective, well, or whether patient's perspective about uses of the your large language model be considered in the development of the LLM.
That's actually an amazing point. We also want to incorporate in our future work. So right now we are only doing summarization facing for physicians. So the patients are not actually involved in this. But at some point we would like to also develop a summary that is facing the patient. This would be a different prompt and maybe even a different model trying to see like if the patient has any questions, if they want to know the details of their case, can we actually address these questions? But we would have to have a lot more safeguards in that solution because right now physicians are experts. So when they actually see the discharge note and then they can see the progress notes, they can tell if something is missing or if there is misinformation or if there are hallucinations, anything that is wrong. But when we are generating something for the patients, we need to have that reviewed by a physician first to make sure that it's not giving any misinformation. So it's definitely something that is on the plan, but we will need to have more safeguards because this like in the case of a physician facing system, we have more confidence in physicians, but with the patient we don't really expect them to know what's right and what's wrong, so we need to make sure that we're not feeding them misinformation.
Yeah, thank you. So another suggestion I would like to have, because it looks like you are doing conduct survey independently, because you're doing qualitative study. Another, you might be kind of doing focus group. So have a group of physicians sitting together talking about the usefulness or other perspective of the model. So can I ask another question? Do I?
Yep, absolutely.
Yeah, so you mentioned about the kind of a develop of the large language model. You consider usefulness, risk, and adjustment of the three perspective. I wonder how you balance those three or two, especially about usefulness and the risk. So for usefulness, of course, if you use more complete nodes or complete data, it will be more useful. But that increase the risk of privacy, right? So how you can balance those kind of a considerations. So if you include in more completely information, might be conflict of privacy. But if you consider privacy, that nodes information might be incomplete.
Yeah, that is also an excellent point that we need to take into consideration. But what we are doing right now is that the data is being only processed on premises, or like the network and the access to the model and the patient data is very limited and restricted. So no one outside the hospital can access it. But the issue we are actually facing is with the token limitation. So the AI model can only take so much text. So we had to limit that to maybe the past 4 days. Ideally, we would want to include as much information as possible because that actually decreases the risk for the patient. But we can't do that because there are some limitations to LLMs. So we are it is definitely a struggle to try to balance all three of them. We want to increase the usefulness in terms of having the physicians do the least amount of work possible, but we also can't risk over reliance because that actually increases the risk for the patients. So it's definitely a struggle. We're trying to iteratively balance that based on the feedback that we are getting and just trial and error, I guess.
Thank you.
Thank you.
Awesome. Thank you, Deepang. And now we'll move on to Melanie for any questions she may have.
Yeah, thank you. This was a great talk, Ghadir. It was really interesting and very well structured. I had a bunch of questions on discussion point and ideas. It was really, really good. I wanted to kind of leverage your answer to Anne's question, actually. You mentioned, physicians are not really normal humans.
Okay.
And, it's part of the using LLMs, which are more generic tools, to a very specific type of data sets. You could and I couldn't remember if you mentioned the size of your sample sets, like how many records have you looked at with how many physicians, but potential options to improve the accuracy and performance of the LLM would be using fine-tuning, for example, but that would come possibly at the cost of the generalizability of your model across a variety of data types. And I'm wondering if you've given some thought about where to balance the choice, right? You could get super accurate and super specific for a very limited type of data, or you could keep it very generic, but then increase the burden on your non-human physicians reviewing. So yeah, I just wanted to get your opinion on what's the right way to look at it.
Yeah, this was definitely one of the main points when we like at the very beginning of this research was what kind of adjustment should we do? So there are so many levels. We can start by just prompt engineering, and we can do things like one shot or few shot learning where we actually incorporate examples into the prompts, and then we can go to fine tuning, and then there is the very unrealistic solution that we would train a model from scratch because LLMs are like not really, we don't really usually have the resources for that unless we were a tech giant. So we did consider this, but we saw that in the literature, people have actually, in the scenario of comparison, of course, they didn't really test that in the real end-to-end scenario that we are doing, but in the scenario of comparison, they tested whether a model was fine-tuned on medical data or just used what they call task tuning, which is like we're not training on medical data, but we're taking a general purpose model, and then we are focusing on this specific task using techniques like prompt engineering. And surprisingly, they found that actually the models that were general purpose and task tuned using like prompt engineering actually performed better than the models who were trained or fine-tuned on medical data specifically. So I think the name for that was domain-specific model versus task-specific model. So they actually found that for clinical text summarization, the task-tuned models outperformed the domain-tuned model. So this is very interesting, and I would love to actually explore that through our scenario, not just as a benchmark. But for now, this kind of gave us a signal into the general direction that maybe we should go with the least expensive solution if it is like if we can see that it can outperform the other one, then at least it wouldn't do significantly worse. And then once we establish a baseline, we can go from there and say, okay, so can we do better if we actually go deeper or not?
Thank you.
Thank you so much.
Amazing. So maybe we have time for another question before we begin the next presentation. If there are any more questions from our adjudicators or from our audience, feel free to raise your hand or let us know. Okay. We have one question.
Hi, wonderful presentation. Thank you so much. And I just wanted to ask about how you chose the language model for your system, because you mentioned I'm not sure actually like if you were actually using the Azure AI, or did you like use a backend server, and then did you like use your own local LLM? And if you did use the own local LLM, like why did you choose Llama specifically? Yeah. Was
Okay, yeah,
there like
so
some criterias or like you were looking at?
yeah, that's definitely an excellent question. So, this was a significant portion of the time, again, at the beginning of the project, trying to determine what type of model we want and what's the criteria, like what are we choosing based on. And I would just like try to summarize it and say that we wanted an open source model. We wanted a model that can be deployed in a serverless deployment because that is much more cost effective and also resource effective in terms of time to deployment and all of that. But we also wanted a model that can handle the context length, which was a significant challenge that we actually faced because a lot of the open source models can't handle they don't have a large context window, so they don't take a lot of tokens. The limit is very little, and when we are dealing with progress notes, they are very extensive and they have a lot of text in them. And then we also have to design our prompts, our system message, all of that. So we actually ran into an issue where we would have to cut down on the prompt engineering part because we want to include as much medical information as possible. And then eventually we settled on Llama 3.3 because it kind of hit all the criteria. So there were available serverless deployment, which meant that we wouldn't have to add any more cost or time for the project. But also it allowed us a good token length of 128K tokens, as input. So it was able to take in progress notes that are extensive and actually generate discharge summaries. We did briefly experiment with other models, but we usually had the issue of token length or the deployment time being too costly, or like whether financially or time-wise.
Amazing. Thank you so much, everyone, for your participation. And we're going to now move on to our second presenter. So our second presenter is David Pellow, a Schmidt AI and Science postdoctoral fellow in computer science at the University of Toronto. As part of the Transplant AI initiative at UHN, David's research focuses on machine learning for healthcare and biology, particularly in modeling long-term cardiovascular risk in post-liver transplant patients. And so now with that, I'd like David to take it away.
Sure, let me just share my screen here. Okay, can everyone see that screen?
Yeah, looks good.
Okay, so I'm David, postdoc in computer science here at U of T. I'll be talking about my work on developing a long-term risk prediction tool for cardiovascular events in the liver transplant population. So this is joint work with Dr. Sarah Naimi Mohassis, who was a research fellow in transplant hepatology. Now she has a position at University of Iowa. And then the other folks that are listed here are mostly people from the data team and the healthcare human factors team at UHN. So I want to start off with the motivation of this project. So over the past few decades, there have been significant improvements in early post-transplant survival. So that means we've gotten better at sort of managing the immunosuppression regimen, at preventing graft failure and graft rejection in the early post-transplant phase. But actually, over that same time period, long-term survival rates have actually remained largely unchanged. And one of the main drivers of this are sort of other comorbidities that aren't directly related to sort of the transplant health itself. And the chief among these are major adverse cardiovascular events, or MACE. So liver transplant patients have a 3 times increased risk of MACE, a 2.5 times increased risk of cardiovascular mortality compared to age and sex matched cohorts in the general population. And so what's been happening over time as we get better at managing this sort of short-term graft health is that the clinicians are shifting to also focus on managing these comorbidities or this long-term patient health. And a lot of times the burden of doing that management falls actually on the transplant hepatologists themselves. So the problem is that there are currently no long-term cardiovascular risk stratification tools for this population. So what ends up happening is that clinicians who want some sort of quantitative measure of the risk in their patients may resort to using tools from the general population. So for example, the ASCVD risk score is a tool that's recommended by the American College of Cardiologists in the general population. It's not intended for our specific population, but it does end up getting used. And of course, the problem with this is that these scores perform very poorly and they're poorly calibrated in our population, which is something that I'll show here. And of course, and this makes sense. I mean, because of all those comorbidities, this population has a very different risk profile than the general population. So the goals of this study were to develop a machine learning model for the prediction of long-term risk of MACE, specifically in our liver transplant population, which can then be incorporated within the EPIC EHR system at UHN. So before getting into the model, I want to talk a little bit about a cohort and the data. So we're looking at essentially all of the patients who've been transplanted at the center here at UHN. So that was almost 4,200 patients since the start of the data collection. No, we don't include everyone, so we exclude patients who were minors at the time of transplant. That's almost 200 patients. And then we're also, again, interested in the long-term health. So we exclude patients who do not survive past 15 months post-transplant. They're sort of the initial time point for inclusion is from 15 months post-transplant. And so that also excludes about 450 patients. And our final cohort that we're using in this study is just over 3,500 patients. On the right, I'm showing the breakdown of those patients. So the number of cardiovascular events, deaths, inclusion, and censoring. To dive a little bit deeper into these demographics, which are these are essentially the features that we're using in our model. I want to just point out some key features here. So first of all, this population here on the right I'm showing is 2/3 male, 1/3 female. It's on the older side, so patients are the median age at transplant is 55.5, and again we're looking at patients who are after transplant, more than 1 year after transplant. So they're on the older side. In terms of indications for transplant, the 2 largest groups are HCC, so hepatocellular carcinoma, which could be secondary to other types of liver disease, and viral hepatitis. But we also have large groups of autoimmune liver disease and alcoholic liver disease, as well as increasing numbers of MASH patients. On the left here, I'm showing these sort of comorbidities and other health status features. So the first number in this column is the number of patients who have that status or have that medication at their initial point and on entry into the study. And in parentheses, I'm showing at the final time point, so either at death or at censoring of those patients. So what we see is that in this population, almost half of patients by the end of the study are diabetic, 2/3 are hypertensive, more than 1/3 dyslipidemic. So it's, as I said, a population with a heavy burden of comorbidities. Now we're using a relatively broad definition of MACE, and this is sort of in line with the most recent literature on looking at cardiovascular disease in liver transplant patients. Using this sort of broad definition, we have 500 patients, just under 500 patients who experience a cardiovascular event during the follow-up time, and that's with a median time to first cardiovascular event of almost 6 years from our starting point post-transplant. Many of these patients actually experience multiple cardiovascular events, so the total number during the follow-up period is just over 900 events. And so if you take a random patient from our cohort and look at some random time point in their follow-up period, the median time to the next cardiovascular event is 42 months, or just basically 3.5 years. At the bottom here, I'm showing a sub categorization of our different types of events, and we see that sort of the largest groups are coronary artery disease and acute coronary syndrome. So now to move on to the methods, I'm using a random survival forest to predict, sort of to do survival modeling. So that means predicting the time to event under censoring. So before I get into the model, I want to talk just a little bit about these specific features. So I have static variables. Those would be things that are available already from transplant. So here on the timeline, TX is transplant. So those are features that are available, such as sex or indication for transplant. We then have, right after transplant, we have this sort of 3-month window where the patient may be stabilizing, and we don't sort of trust any of the labs or anything like that from that time period. And then we look at 1-year windows from that point onwards. And at each 1-year follow-up, we have the most recent health status, medication list, BMI, labs, etc., and we're able to make a prediction from any of those follow-up dates. Now, the random survival forest is basically an ensemble tree-based method. So it's made up of a set of random survival trees. A random survival tree is basically a decision tree where the way that it's constructed is you take the entire population and you iteratively split it into subpopulations, where the splitting criteria is basically to have the two subpopulations be as different as possible in terms of their estimated survival. And then you ensemble over the entire set of trees in order to get your prediction. Now, the prediction is not actually a specific sort of one number that's prediction of the risk. It's actually this model outputs a survival function. So it's a function of time, and it gives the prediction is actually this probability of surviving event-free up to time t, given all of the patient's covariates. So we can make a prediction at any time, at any date in our follow-up period, and then we can evaluate the sort of the predicted function at 10 years post-transplant. That gives us the probability of being risk event-free, and the risk is 1 minus that probability. Okay, so now that we have a model, how are we going to evaluate its performance? So as I mentioned, the ASCVD risk score is the recommended one by the American College of Cardiologists. And so we're going to compare what happens if we apply that risk score to our method on a held out set of test patients. That was about 15% of our cohort, so just under 530 patients. And for each of those patients, we're selecting a random follow-up time point, and then we can sort of rerun that randomization multiple times to get an error distribution. So the metrics that we're using are the two of the key metrics that are used for survival analysis are the C-index and the Breer score. The C-index looks at comparable pairs of patients, so patients where the earlier event time is uncensored. And it looks at all pairs and evaluates the proportion of those comparable pairs where that are correctly ordered by the predictor. So that means that the patient with the earlier uncensored event time was predicted to be at higher risk. So it's a metric that looks at basically the relative ranking or the relative ordering of pairs of patients. The Breer score is more interested, sort of more focused on the calibration of the actual predicted probability. So it's similar to the mean squared error at some specific follow-up time t, and it adjusts for censoring by using this weighting of the inverse censoring probability. Cumulative dynamic AUC is somewhat similar to the concordance index. It's looking at the correct ordering of pairs of patients. And finally, another way that we're interested in looking at the calibration is looking at the actual risk categorization of patients. So we're actually interested not just in not only in the sort of specific predicted risk, but in the risk strata that a patient falls into. So low risk patients have predicted risk of below 7.5%, intermediate is 7.5 to 20%, and high risk patients are greater than 20%. And so what we're able to do is take all the patients that fall within one of these strata according to either the ASCVD risk score or our method, and then evaluate or estimate the actual empirical risk among all of those patients using a Kaplan-Meier estimator. So here I'm showing the performance at the top in this table. The first line of that table is the ASCVD score. So in terms of the C index, we see that a C index of 50% would basically be random guessing. So this is not doing that much better. We're achieving a C index of almost 70%, so it's like 25% better. The Brier score is an error metric. You want it, the lower is better, and we're doing about 20% lower than the ASCVD score. And now CD AUC is similar to the C index, and that final metric is looking at within each strata the absolute error between the average predicted risk and the empirical estimated, Kaplan-Meier estimate of the risk. And we're taking a weighted mean over all of the three different strata. So it's weighted by the bin size of that risk category. And what you see there is that the ASCVD score is off by like almost 9% in terms of its estimation of the risk, whereas we're within 3.5% of the estimated risk. And now I'm showing these results visually below. What you see here is the low risk patients in green, intermediate risks in yellow, and high risk in red. And what you're seeing from the ASCVD score is that the actual empirical risk on each of its predicted strata are not that different. So the worst case scenario for this type of for one of these models would be for you to have a horizontal line where all the different risk categories are exactly the same size, and they're all predicting the empirical risk in each of them is exactly the same, which would basically suggest that you're doing random assignment of patients to risk categories. And as you see, the ASCVD score is actually not doing that much better than that. On the other hand, our model, which we're calling LTCVD, is doing significantly better. So the low risk category is quite small. As I said, this population has a severely elevated risk of cardiovascular events, so we don't expect to see many patients in that bin. And the low and intermediate risk bins are basically perfectly calibrated, while for the high risk bin, we're doing pretty well, and we're slightly over predicting the risk. So according to the clinicians that are working on this, that's basically being conservative. So they're okay with that sort of conservative estimate of the highest risk patients. So now we're interested also in doing some introspection into these predictions. So we're using the SHAP attribution method. So these are the Shapley values that estimate the contribution of different features to the change in predicted risk above or below the mean risk in the population. So the way you read this plot on the right here is that each line is a different feature. And then for each feature, we have the distribution over the whole test set. So each dot here is one patient in the test set, and the color indicates the value of that feature for that patient. So more red is a higher value, more blue is a lower value. And the x-axis shows how much that value of the feature contributed to changing the risk of the patient, the predicted risk of the patient compared to the mean risk in the population. So if you look at, say, two of the continuous features like creatinine and age, what we see is that a increased value of that feature increases the risk, decreased value of the feature decreases the risk. Similarly, we have a lot of indicator variables. So the history of cardiovascular events, or the status in terms of the diabetic or hypertensive status of the patient, those are either bright red for positive status or bright blue for negative status. And again, we see that patients with positive status have increased risk, negative status have decreased risk. And so the key takeaway here is that a lot of the sort of most contributing features to our predictions make a lot of clinical sense. They sort of align with the assessments of the clinicians that we're working with. We can also look at individual predictions. So here on the left, I'm showing a patient who was age 58 male, transplanted for alcoholic liver disease, HCC. He has severely elevated creatinine, so some severe kidney injury or late-stage kidney disease, history of cardiovascular events, diabetes, etc. And this patient was predicted to have a very high risk. So all of these factors add up to a predicted risk of above 36%, which is well above the cutoff for 20% for a high-risk patient. And so this patient, in fact, did suffer from a cardiovascular event in our test set within 10 years of this prediction. On the right, I have the opposite case, so a young female patient who's diabetic but otherwise has no risk factors and was predicted to have a very low risk. And this patient did not suffer from a cardiovascular event within a 10-year window follow-up period of this prediction. On the other hand, we have, of course, incorrect predictions. So on the left, I'm showing a patient who has basically all of the risk factors, and these add up to a very high predicted risk of 46%. But he did not actually suffer from a cardiovascular event within our follow-up period. And sort of these types of false positives are okay. So if we had a well-calibrated predictor, patients with predicted risk near 50%, basically around 50% of the time, we wouldn't actually expect to observe an event. And so the fact that we don't observe an event is okay. And of course, we are happy that this patient was predicted to have a very high risk. I mean, if you're looking at all of the risk factors, we definitely want to be able to flag them as being at high risk and make sure they're being managed and followed as a high-risk patient. On the other hand, we also have these false negatives, where we have on the right a patient who has no risk factors predicted to be in the low-risk category, but during the follow-up period, within 10 years, actually did suffer from a cardiovascular event in our test set. And so the main thing I want to point out about these false negatives is that they're extremely rare. So we have in our test set around 530 patients. As I mentioned, of those, 80 to 90 are in this low-risk category, and of those, 2 or 3 patients are these sort of false negatives. So it's an extremely rare incorrect prediction. So now that we have this model, and we've shown that it works well on our population and that we can sort of visualize the predictions in a way that makes clinical sense to the clinicians we're working with, we were interested in embedding it into the EPIC EHR at UHN. So this is work that was mostly done by Peter Maksimowski from the data team. And we have a transplant AI server at the hospital, and he's built in that server a database which basically pulled in legacy data from our transplant registry, which is at this point offline and not used. Plus, there's regular pulls of the sort of currently updated databases on EPIC and other databases within UHN. From that database, the patient features can then flow into the model, and we can get back predictions and the Shapley analysis, which can then be served in the dashboard to clinicians. I'm going to just show quickly what that looks like. So here we have a chart of a patient. We're looking at their liver summary, and we can go to the Transplant AI dashboard. Here we're showing this patient is predicted to have low risk. Below that, we show the contribution of various features. When you mouse over the Shapley value, you can see the actual value of that feature that contributed to the prediction. We also have a little feedback pane for the doctors to be able to provide feedback at this stage as we're developing this. And they can also view all of the data of that patient that went into making the prediction. On the right-hand side of this window, we also have a pane with recommendations for patients in that risk category. So those recommendations were developed by Dr. Naimi Mohassas. Basically, she developed very extensive new SOP with risk management guidelines for cardiovascular risk in post-transplant patients. That was essentially done by taking the AHA guidelines in the general population and extensively adapting them based on the literature and what's the clinical knowledge of that cohort, adapting them to our population. And then what we did was take those longer guidelines and shorten them and give very brief summaries that can then be displayed within the dashboard. So in summary, our patients are at an extremely heightened risk of MACE, which has significantly compromised their long-term survival. In order to be able to better manage that risk, we're not actually able to use standard cardiovascular risk scores from the general population that cannot be applied to this unique population. And so what we've done is develop a machine learning tool that can predict risk specific in our liver transplant recipient population. We then developed it into a dashboard in order to better enable clinicians that we work with to manage the risk of their patients. Our next steps are, first of all, to do some sort of external validation. So we're currently working with the University of California Health Centers. We've sent them our model, and we're working on having them build the cohort and do the pre-processing of the data in order to run our model and get their predictions on their cohort. And that's something that's underway. As I said, we hope in the next weeks or a couple months to get those results. Of course, we also want to assess the usability of our predictions, the dashboard, the user interface with some of the transplant hepatologists at UHN that will be interested in using this and think about the potential impact on their clinical practice. And long term, we would like to assess any any impact on patient outcomes. So I want to thank everyone that's been involved in this project, especially Dr. Suriname Mohassis and Peter Maximowski, who have done some of the work that I've shown here, and I'm happy to take any questions.
Thank you so much, David. So now we'll open up the floor to our adjudicators first. Does anyone want to go first? Anne, perfect.
Go first. So how are you going to assess any drift in this model? So some of the variables that you've got in there, like things like the administration of drugs and things like that, practices on how they do that might vary with time. So that might change the kind of underlying distribution of your patients and therefore the model output. So what are your thoughts on how to monitor this over time to check for safety?
Yeah, so we haven't figured out exactly the follow-up times that we want to do these regular assessments. So it may be like 6 months or 1 year or more than that, but definitely every sort of regular at regular intervals, we plan to sort of rerun, sort of both redo the training and compare sort of the predictions from a retrained model on the newer, latest data with the existing model. That's the plan.
And it looked like, I can't remember exactly what all your features were and whether they had any impact, but one or two of them were actually on administered drugs. So
Yeah.
is there a possibility that the clinicians have assessed that patient as a higher risk anyway and administered?
Yes. So that is exactly what we're seeing. So this is a predictive model. So these are correlations. It's not like we're not saying that giving antihypertensives causes higher risk of cardiovascular disease. Of course, the causal direction is the opposite. But in terms of being able to predict, pick up features that are predictive, we're seeing exactly that. That the highest risk patients are the ones that are on the drugs. And so that being on the drug, that indicator variable of being on an antihypertensive is contributes to the predictive power of the model, but of course is not causal. Yeah.
So isn't there an argument for eliminating those features, because that could really affect? It's like the traditional New York pneumonia prediction, wasn't it? That the patients who had severe asthma were assessed to have a lower risk because they were being aggressively looked at, but then that can have the opposite effect, that they wouldn't be admitted after the model was input because they had a low risk. So is there a danger that by incorporating these parameters that are reflecting the assessment of risk, that you're actually damaging the model performance?
So I don't think it affects the predictive performance, but I guess what you're the analogous case to the pneumonia case would be basically that patients who are not on antihypertensives are being predicted to be at lower risk, and so then they're not being put on antihypertensives. So I guess that is a slight risk in terms of the actual contribution. I think most of the contribution comes from being hypertensive first of all, and then there's like this small addition. But yeah, I think it's something that we should consider as well. Yeah.
Thank you, Anne, and Dipeng, yeah, for sure.
Thank you. So very interesting research. So I first want to ask one kind of a more technical questions. So I'm not familiar with the random survival forest model, but I wonder, because in statistics, when we do a model for time to events survival, we kind of make distinguishing between we call terminal events and non-terminal events. So terminal event, I saw you have some transplant patients, they died, so they no more. But non-terminal, like the MSCE, the major adverse cardiovascular events. So those can be happened, then you can lead to that. There's how those kind of a different type of, especially how death being considered when you develop the risk predicting model.
Yeah, so we don't distinguish between those two types of events, but so what we are doing is basically breaking each patient into like multiple different pseudo patients basically. So at each follow-up time point, we consider them as a new patient. So we would be predicting, when we're predicting, let's say, a patient's second event, that would be the features would be features that were collected after their first event. And then that sort of the fact that they have had that first event is sort of one of the features that goes into the model.
Thank you. So Another question is I have, I think Anna also asked, it's very important information. I think you also discussed in your discussion section about use kind of longitudinal features of some of these kind of variables, like I think medications use and changes over time, some of other patient features, how they change over time. That might be very important in predicting or develop those risk models. So another question I want to ask, so right now you kind of develop model without kind of mostly when we're doing machine learning model, we have kind of a training set, supply training set, test set, but I don't see you did that, or why reason is it because the small sample size, or?
No, so we do have, so all of the results were shown on a held out test set. Yeah.
Okay.
Yeah. So
Okay.
we had about 3,500 patients. We did 70% were training, 15% validation, and 15% test, and all of the results were shown on the test set. Yeah.
Okay, that's great. I probably missed that. Yeah, thank you.
Awesome. Thank you, Deepang. And now Melanie, if you have any questions.
Sure, thanks, David. That was really interesting. The very low rate of false negative, I think, was really good because you'd rather have a couple false negative, but not miss any of the really high risk ones. I was going to ask about the longitudinal assessment, in particular with your risk management guidelines, because I think looking at that and how to codify and evaluate the impact of the treatment, it's going to be really, really interesting in terms of reassessing the model as time goes on. But instead, I'm going to ask you about, you're talking about cardiovascular events for liver transplant. How do you think that could be repurposed and reapplied to other types of transplants and other type of event? Because it was really cool, like you're showing, the model building to the evaluation to the implementation in Epic. It sounds like it's something, if it was relatively straightforward, I never want to say straightforward, it never is, but if it were relatively easy to port it to other type of events and transplant, that could be really interesting.
Yeah, you're right. So I actually, so I didn't put this into the next steps, but definitely one of the things we're thinking about is that this is sort of in liver, it's a pilot for the other solid organ transplant programs. And if it works here, again, it's, as you said, relatively straightforward to sort of define the cohort in the other with the other organs, do the same sort of training, validation and testing, and then deployment. And so one thing about the way this dashboard is being built out, it's part of the Transplant AI initiative. It's basically being built out in a way that we can extend it relatively easily, both in terms of like reproducing, so using like the same UI and the same backend for different predictive models. Also, I think in terms of like the way the approval and like REB process for adding new models into that dashboard, it sort of it will allow us to extend to various different predictive models within the transplant or sort of the world of transplant predictions.
Okay, and so it's feasible to, like you talk about the North American guidelines, but we know different countries have different type of guidelines. For example, I'm sure UK has a slightly different definition of what the cardiovascular event is or things like this. So there's an option to use that as some sort of configuration to the tool.
Yeah, so the way the guidelines work is basically these types of guidelines are like they're like the standard operating procedures within, so they're hospital specific. So this is what Dr. Naeem Hassis did, was like develop specific UHN specific guidelines like for this center. But then the way it works is we've then taken those and summarized them into like these very short sort of single panes that can be shown within the dashboard. And so that part of it of like so in any new center or any new system where the guidelines are different, they would have to, again, do the work of sort of developing those guidelines, but we could shorten them and serve them in the dashboard relatively easily. Yeah.
Thank you.
All right. Thank you, everyone. Thank you both to our presenters, Ghadir and David, for your insightful presentations. I think everyone here took away some really insightful comments and is looking forward to the future. And again, thank you to our adjudicators and everyone who attended for your participation. So we hope you enjoyed our trainee rounds for today. And as a reminder to our T-CAIREM summer program students, our next session will be a professional development session on Thursday, June 5th with Dr. Amol Verma. And with that, I'd like to thank everyone for attending and wish you all a great afternoon.